Hello, and welcome back to Wellness Wednesday, a monthly series where experts share practical tips and techniques on topics that are important to patients, survivors, and caretakers alike. I'm Erin Kuhn-Krieger with Ralph Pancreatic Cancer Foundation, and I'm so excited to be back tonight moderating tonight's session, where I'll be welcoming back Dena Goldberg of DenaDNA to talk about genetics and hereditary pancreatic cancer syndromes. We've got a great conversation ahead of us, but before we get to Dena, I want to share some about our upcoming events. So on Thursday, September 15th, we're partnering with Twist Out Cancer for a Brushes with Cancer overview. And I was researching this morning, and it's really a fascinating idea. What they do is they pair artists with somebody that's been touched by cancer. So whether it's a patient, a caretaker, a family member, a warrior, and then through that partnership, they create unique pieces of art that are reflective of that family's journey. So this event will be an information overview to see all the details there, and you could sign up to attend by clicking on the link in the notes below. And don't forget, our annual fall event returns on Friday, November 11th, when Friday night Lights of Hope hits the Glen Club in Glenview. You could join the Ralph community during World Pancreatic Cancer Awareness Month as we honor loved ones and celebrate those who do spread lights of hope. We'll have members of Chicago's famed Gold Coast All-Stars to rock out the dance floor, amazing food, signature cocktails, and auction games, and so much more. So early bird tickets are available right now, and the link to purchase those will be in the chat. And be sure to be watching all of our social channels in the coming weeks as we share more details and give more insights. So a few housekeeping items. You can ask questions throughout tonight's conversation. We'll hold all of those questions till the end to make sure that we get to everybody's. You can ask those questions by putting it in the chat, or if you want to do so with a little anonymity, you could also email us at info@ralphfoundation.org. Again, we'll save all the questions until the end to make sure that we get answers. So Dena Goldberg is a licensed and board certified genetics counselor in Los Angeles and the founder of DenaDNA and Malibu Genetics Concierge. Dena completed her Bachelor of Science degree in integrative biology at the University of Illinois at Urbana-Champaign, and she received her master's degree in genetic counseling from the University of California at Irvine. She's currently certified by the American Board of Genetic Counseling and licensed by the State Medical Board of California. Welcome, Dena. We're so excited to have you back.
Thank you. I'm excited to be back today.
Enjoy.
All right. Okay, let's just make sure this goes on. All right. Okay. So hi, everybody. Today I'm going to be talking about hereditary pancreatic cancer syndromes and demystifying them a little bit. So before I jump in, I just want to answer this question that's usually the first question most people have when they meet me, which is, what is a genetic counselor? So if you are aware, or maybe you're not aware, but most doctors and other healthcare providers only have very basic training in medical school in genetics, if any, and genetics is always changing. And it's the future of personalized medicine. So really any healthcare team working with genetics needs someone who understands the ever-changing field of clinical genetics. And that's where genetic counselors fill the role. And so as genetic counselors, we stay up to date on the latest research and recommendations in genetics and genetic testing. We translate complex information for patients, communicate with healthcare teams, and we do all of this in a way that is ethical for patients and their families. So, hi, I'm Dena. I am a genetic counselor, and I used to work at UCSF where I did research in pancreatic cancer and disease. And I also founded DenaDNA, which is my online social media persona, teaching people about genetics and healthcare education. And I recently opened my private practice, which is called Malibu Genetics, which is a concierge genetics practice. So just a quick plug, if you are interested in following me on social media, would love that. And I think there's a lot of great stuff that I think will be helpful. And through Malibu Genetics, I am now also accepting patients in multiple states using telemedicine. So if you're interested, you can send me an email. And if you mention Ralph, I can provide a discount for you if you're interested in genetic counseling. So this is my publication that came out. I was a co-first author on, came out last year, and I'm going to summarize it at the end of this talk. But before I do that, let's jump in and just talk about the basics. So if you've seen my other videos, specifically the one 2 years ago that I did with Ralph, it was really getting into the nitty-gritty of what the pancreas is and hereditary changes in what they do to the pancreas. But today I'm going to kind of breeze through this part so that we can move on and talk about the syndromes. But if you're interested in a deeper dive in this part, then I definitely recommend watching the first video that I did. But just to review, the pancreas has two main functions, and those are digestion and blood sugar regulation. And so there's two main glands of the pancreas, which are exocrine, which produce enzymes for digestion and are released into the digestive system. And then endocrine, which are hormones to control blood sugar that are released into the bloodstream. So two different kind of systems in one organ. And when we talk about cancer, most pancreatic cancer, when we hear the term pancreatic cancer, is an exocrine type of cancer. And it's usually PDAC, or pancreatic ductal adenocarcinoma. So when you hear me say PDAC or PDAC, that's what we're talking about. And there's also other types of pancreatic tumors. And then there are also much less common endocrine or pancreatic neuroendocrine tumors. And for these, today, for the purposes of today's talk, I'm going to be focusing on the hereditary syndromes that are associated with PDAC. This is really important to know if you do have a pancreatic cancer diagnosed, which type of tumor this is, because it's a very different treatment, prognosis, and the genetics are very different. So what causes cancer? Well, cancer is simply a disease of aging cells, or a really uncontrolled cell growth. And from a genetics perspective, we kind of see it falling into three different categories. So there's hereditary, familial, and sporadic. Now, what does that mean? A sporadic cancer, which is the most common type of cancer, is usually when we see a family with one person in the family affected at an average or older age, which with the more common type of cancer. And these are usually due to more exposures or environmental things and not so much genetics, and sometimes a little bit of bad luck. And so typically someone who has a true sporadic cancer, their relatives would not be at an increased risk. If someone has a familial cancer in these families, we see clustering of similar cancers at average or older ages. And this is probably a mix of environment and genetics together, shared diet, lifestyle, and shared location where you were born or grew up can also mean shared risk factors. So these we can't use genetic testing for at this point in time. But that leaves us with the last category, which is hereditary. And in these families, we usually see multiple generations of cancers at younger than average ages, cancers that go together with specific genes or syndromes. And this is because of a single genetic change that passes from parent to child. And so we can use genetic testing to determine if somebody falls into that hereditary category. So there's this term we call familial pancreatic cancer, and there's a lot of ways to define that. But the most common way that we're defining it in the kind of cancer research community is when a person has two or more first-degree relatives, that means a parent, a sibling, or child, with pancreatic cancer that doesn't have a known genetic cause. So in those cases, if somebody's had a true full panel and there's no explanation, then they're considered to have familial pancreatic cancer and they're put in that category. But a lot of times we're finding these genetic mutations, and as technology gets better and it's easier to incorporate into medical care, we're actually discovering new genes and their roles in the formation of pancreatic cancer. So these numbers that are listed here are going to be actively changing. So what are cancer genes? When we think of cancer genes, we usually think negatively, right? Well, in every cell, we have about 20,000 different genes. And what a gene is it's basically just a recipe for the cell to create RNA, which a lot of people now know because of the COVID vaccine. So RNA is what DNA creates, and then the RNA creates a protein. And the protein is what our body's made up of and tells our body how to function. And so when the genetic code is spelled wrong, or when there's a change that creates the wrong type of product, then it creates this RNA that then goes on to create an abnormal protein or no protein at all. And that's what we call a mutation or a pathogenic variant. It's when the DNA is not functioning the way that it should. So cancer genes are actually good genes. They protect our cells from becoming cancer. But when there's a mutation that alters the function, that's when they're bad. So that's when people say, if someone says, I have the BRCA gene, well, we all do. The issue is having a mutation in that gene. So how are these genes passed down? If you took biology class, that may have been a long time ago, you may remember that we have 2 copies of every gene, and we pass one, we get one from mom and one from dad. And when we have children, we pass down one and the partner passes down the other. And so that's how all the genes get passed down. So let's say we're taking somebody random off the street, and we see that we're looking at all their cancer genes, and they don't have any mutations. They're all functioning normally. Let's say 30 or 40 years goes by and they acquire a random mutation in a random cell in their body. Well, there's that second copy that can do its job and protect the cell from becoming cancer. And so that cell will be fine. Then another 30 or 40 years goes by and the second copy acquires a mutation. Now that cell no longer has that protective mechanism and may turn to cancer. And so as you can see, it takes decades for that to happen, and it takes a lot of different things for these gene changes to occur. Now, let's say we're kind of rewinding back to that first sample, but in this example, one of the parents already had a non-functioning copy of a gene that they passed to their child. Now that child, every single cell in their body will be affected with that mutation. So that first 30 or 40 years goes by and the first acquired mutation happens. Well, that person may develop cancer in half the time as they would have if they were born with 2 functioning copies. And so that is a very simplified explanation of how hereditary cancer risk works, but I find that it's very helpful for my patients. So what are the chances if you do have one of these gene changes that you're going to pass it on? Well, it's 50%. So if we look at all these different combinations of the ways that these genes pass on, half of all offspring will inherit a gene change and half will not. Meaning each time you have a child, it's about it's a coin toss each time whether the child inherits that condition. And if you don't have that condition or that non-functioning gene, you can't pass it on. These do not skip generations. So there's 2 types of genetic testing. And as family members or patients with pancreatic cancer, you probably have been offered at least a tumor genetic test. And what that's looking at is it's looking at the genes in the tumor to see what changes occurred for that tumor to become cancer. And that can help the oncologist with treatment planning, right, and targeting therapies. But that doesn't tell us if those mutations were both acquired over time, or if the patient was born with one and acquired a second one. So that's where germline testing comes in, where we actually look at someone's blood or saliva to see if they were born with one of the mutations in the cancer or not. And this can be used to determine the cause of the cancer, find risks for other cancers they may have. It can inform treatment plan, identify other family members at risk and how to lower that risk, and can give clues as to the tumor behavior. So these are 2 very separate tests. And today we're focusing on these germline genetic changes. And if you've had these testing, they may look like this. So they typically are separate companies, although there's some companies that are doing both. But I do like to recommend that if somebody's only had one, that they have the other test. If they've only had tumor testing, they have a germline test as well. And that's because we're going to go into why that is important. But some of the germline testing companies could include Invitae, Ambry, Myriad, Natera, Color. There's lots of different germline genetic testing companies, whereas tumor profiling, molecular profiling companies may be Foundation One, Tempus, Genomic Health, Oncotype GX. There's several of those too. So if you believe you've had genetic testing, it's important to understand whether you've only had tumor testing or you've had both. As I said, germline testing is done through blood or saliva, looking at white blood cells. And so who should get this testing and what should they be tested for? So the National Comprehensive Cancer Network's latest guidelines state that all individuals diagnosed with an exocrine pancreatic cancer, exocrine being the category we talked about earlier, so the pancreatic ductal adenocarcinoma or one of those other rare types, they should all be offered germline genetic testing. And first-degree relatives of individuals should also be offered this testing, which means because these are the guidelines through NCCN that we can typically get insurance to cover this testing. So what are we testing people for? Well, the NCCN has these base genes that are going to be the most important, and we're going to go through each of those today, talk about what they are. But there are a few extra that I believe for my practice are really important as well. And the NCCN also recommends that testing first-degree relatives should only be done if you can't test the person who has the cancer. So it should always start out with the person who has been diagnosed with cancer, because if there is a mutation, they're the one that's going to have it, and that will inform the care for the rest of the family. So if possible, the person affected should be tested first. If not, then their close relatives should be offered testing. Okay, so when we talk about evolution, there's this really neat concept, if you're into biology, where the way we've evolved, we know that the mutations that confer a very large disease risk are usually more rare in the population, and the ones that have a lower risk are sometimes more common, often. And so when we talk about these germline genes, so there's lots of different genes that have different jobs, and when there's mutations in different genes, they all have different amounts of risk that they confer. And so when we do this genetic testing, it's easy to test these that are high risk or moderate risk, because a single gene change can tell us a lot. But when we're thinking about these lower risk alleles, so the ones that are kind of towards the right, it's harder to do a test there because individually they're low risk, but they add up. So when we think about familial pancreatic cancers that are unexplained by these hereditary germline panels, it could be that these families may have multiple genes that work together and maybe also work with the environment to increase the risk for pancreatic cancer. And at this time, that type of testing is because it's so complex, it's not ready for prime time. But I do believe in the future, we're going to be able to test for some of these lower risk variants and add up that risk. And so when we talk about these hereditary syndromes, they range in the amount of risk that they increase for pancreatic cancer, starting with this gene called STK11, which has 132 times increased risk for pancreatic cancer. And it's very rare, but we'll talk about that. And then we're going to go down this list. So I'm going to start out now talking about these syndromes with probably the most common mutation that is on this list today. So let's go back to the 90s in Tel Aviv. These university researchers were trying to figure out what was causing this severe neurological and immune system disease in childhood for all these children. It was called ataxia telangiectasia. They were trying to figure out what was causing it. And what they found is that this gene called ATM, when inherited from both parents, caused this severe disease. So this is a recessive disease that both parents would pass down this abnormal gene. But what they also found is that the mothers of these children had much higher rates of breast cancer. So that made these researchers look more into ATM and its role in cancer progression. And so what they found is that most people are non-carriers, but 1 in 100 people carry an ATM variant. And if you carry one variant or one mutation, then you have an increased cancer risk. And if you have two, then you have this severe disease. So what cancers does that mean that someone might be at risk for? Well, the biggest is breast cancer. There's also prostate risk, and then pancreatic cancer. So we do see in many of these families higher rates of pancreatic cancer, and possibly others as we study this more. So what does that mean for somebody who has an ATM mutation? Well, usually the risk for breast cancer is not necessarily thought to be high enough to recommend a surgical intervention, which is recommended for some of the higher risk breast cancer genes, but we do recommend imaging studies. And that may begin at 40 or 10 years prior to the earliest breast cancer in a family. There's also prostate exams. There's no standard pancreatic cancer screening. but it just depends on the center. So there's kind of this back and forth as to whether people with these mutations should be offered that screening. And so again, it depends on the medical center. The other really important thing is partner testing. So not only is this important for cancer risk, it's important for reproductive risk, because if someone carries an ATM mutation and their partner does, then there's a 25% chance they could pass it on and have a child with the severe condition ataxia telangiectasia. So this is one that actually often gets picked up on carrier screening when people are family planning or when they're pregnant. So this is one of the more common ones. Now, the second one is the most common form of hereditary or of inherited pancreatic cancer. So most of the time when we do find a genetic change, it's usually in the gene BRCA2. So the BRCA genes cause this syndrome called hereditary breast and ovarian cancer syndrome. They're named the breast cancer gene and were discovered in the 90s, but it's kind of a misnomer because there's a lot more cancer involved than just breast and ovarian cancer. And we know about 1 in 400 people in the general population carry a mutation in BRCA, but for those who have Ashkenazi Jewish ancestry, it is 10 times higher. So 1 in every 40 people do. So anyone who has Ashkenazi ancestry and has breast cancer, ovarian cancer, pancreatic cancer, prostate melanoma should absolutely be tested for the Ashkenazi Jewish mutations. But also, even if there isn't a family history, it can be really important because it's a really high number. So her HBOC is caused by mutations in BRCA1 and 2, which are considered tumor suppressor genes. They regulate cell division. And the risk of cancer depends on which one of these is mutated. Now, a little backstory. Because of BRCA1 and 2, there was a Supreme Court case. So one of the labs that tests for BRCA1 and 2 had a monopoly over the testing for many years. And the cost of this testing was thousands of dollars. And they had this patent on the BRCA1 and 2 genes. And so this case was brought to the Supreme Court, who ruled that you cannot patent a natural substance, you can't patent a gene. And so it was overturned, and all these other labs started offering it. And it really helped lower the price and increase the availability of this testing. So that's a little history. And then who made it famous? Well, Angelina Jolie came out, I believe it was in 2008, I think. I might be wrong, but she came out and talked about how she was positive, and so she decided to make the decision to have a bilateral mastectomy and oophorectomy, and that really increase the amount of people who came in for genetic testing and really put cancer genetics on the map. And so people who have BRCA1 or 2 mutations, the biggest risk is female breast cancer and ovarian cancer. But there is an increased risk for pancreatic cancer as well. And like I said, usually when we're testing people with pancreatic cancer, the most common genetic change we typically see is in BRCA2. There's also risk for aggressive forms of prostate, male breast cancer, and melanoma. And so, and there's this recessive risk. So if you carry 1 copy, you have HBOC, but if you carry 2 copy, or if you pass down a copy and your partner passes a copy of the same gene, so it has to be either both in BRCA1 or both in BRCA2, it causes Fanconi anemia, which is another very severe childhood onset condition. So it's really important to have partner testing in these situations as well. And so what does it look like if somebody has a BRCA mutation? Well, I'm going to be kind of breezing over this because if you do have one of these, it's really important to meet with a medical professional, but I want to give you an idea of what it could look like. So this could be choosing to do a risk-reducing surgery to remove breasts or doing extra screening, and it can be either or, and there's benefits and limitations to both. Also, it's recommended to have the ovaries and fallopian tubes removed when someone's done having kids. Pancreas screening is questionable. So for people who carry BRCA mutations, who have a family history of pancreatic cancer, they are typically offered pancreatic screening. But if you don't have a family history, there's some debate as to whether we should offer it to everybody who's a BRCA carrier. So that's something that I think will hopefully be more clear in the coming years. There's also prostate exams and testing, total body skin exams, and partner testing for Fanconi anemia. So that's kind of what it would look like. And this screening and awareness usually starts in the 20s. So it's really important to know as soon as somebody can find out for females. The other gene that's kind of similar to BRCA is called PALB2. And for many years, people were only being tested for BRCA1 and 2. And there are all these family histories that were remained unexplained of breast cancer and pancreatic cancer and other types. And it turned out that when we went back and tested a lot of them, that they had this PALB2 gene change. And it literally is called the partner and localizer of BRCA2, another tumor suppressor gene. And in these cases, if you have a PALB2 mutation, again, it increases the risk mostly for breast, but also for pancreatic and possibly others. And so this is one that has kind of similar screening to BRCA. And then also can cause Fanconi anemia if found recessively or in both copies. So that brings me to the next syndrome, which is another really important one when we're thinking about pancreatic cancer, which is Lynch syndrome. And Lynch is actually more common than BRCA. It is the most common hereditary cancer syndrome out there. And it's named Lynch. People get scared by that name, but it's Dr. Lynch who discovered it. And it used to be called HNPCC, or hereditary non-polyposis colorectal cancer syndrome, but we now know that that is very outdated and a misnomer because it doesn't include all these other cancer risks. So we know about 1 in every 280 people have Lynch syndrome, and only about 1.2% are aware that they have it, which is awful, right? So there's so many people out there walking around with Lynch syndrome that aren't aware they have it. So I'm going to give you the signs to look out for, because if you have it, you can take specific actions to lower your cancer risks and prevent cancer. So Lynch is caused by a mutation in one of 5 different genes, and EpCAM and MSH2 work together. That's why I have them connected there. And these genes are all called mismatch repair genes, or MMR, which means basically that they're spell checker genes. So when we accumulate errors in our DNA, when our cells are reproducing, these spell checker genes go in and they fix those errors. And so this is going to be important later, because immunotherapy options for people with different cancers respond really well to people who have mismatch repair deficient tumors. So that's something we'll come back to. But the risks of cancer for people with Lynch syndrome depend on the gene that's affected. So for example, the highest risk gene is MLH1, which has a pretty high risk for colon and uterine and ovarian. And then the others are a little bit lower. So we really focus on the things that we can screen for, and that are as the highest risk. And MSH2, a little bit lower. MSH6 is a little bit lower even still. And then we have PMS2, which is actually questionable if it's even really associated with pancreatic cancer. So some guidelines actually don't include PMS2, they include all the other Lynch genes. So if you have a PMS2 mutation, we don't really know if that causes an increased risk for pancreatic cancer, but there's still a lot that we're learning. And if you have Lynch syndrome, it also has a recessive risk. So if you have a mutation in one of the Lynch genes and your partner has in the same Lynch gene, and you pass on both of those mutations to a child, then they will have constitutional mismatch repair deficiency, or CMMRD, which is yet another childhood onset condition that's very severe. So another reason that people should know they have this, because not only is it helpful for them, but for their children as well. And so what does this screening look like? Well, this means if somebody has Lynch syndrome, we recommend colonoscopies starting in the 20s, because people who have Lynch syndrome have a much higher chance of developing polyps that will then turn to cancer at a young age. And so if we can go into the colonoscopy, remove the polyp before it has a chance to become cancer, we can effectively prevent colon cancer. Now, it's not 100%, but it's very good at lowering that risk. There's also the upper endoscopy looking at the stomach, same type of thing where you're removing polyps. And then there's some gynecological intervention as well, skin exams, and then aspirin therapy. So in patients who have Lynch syndrome, there are really good studies showing that taking high doses of aspirin can really significantly decrease Lynch cancer rates. There's also oral contraception, which decreases gynecological cancer rate, and then partner testing to make sure you don't have a child with CMMRD, as I mentioned earlier. So this is what that could look like. But again, it depends on the situation, and it's a conversation for a patient and their medical provider. Now, this one, FAMMM, or familial atypical mole melanoma syndrome. If you've ever heard that there's a link between melanoma and pancreatic cancer, this is it. So CDKN2A is a gene that creates two proteins. One's called P16, one's P14. When there's a mutation in the region of the gene that creates the P16 protein, we typically see pancreatic cancer and melanomas in those families and many moles. So people with FAMMM typically have over 50 moles on their body. And so the biggest risk for them is going to be melanoma, but there's a pretty high risk for pancreatic cancer in these families. So the recommendations are, if you have a mutation in the area that encodes for the P16 protein, that you are offered pancreatic cancer screening. So what do we do for these patients? Obviously, sun health and sun safety behaviors are really important in this population because of the melanoma risk. We do total body skin exams. People do their own self-exams, wearing lots of sunscreen. And this screening starts at age 10, so really early. And also eye exams look for ocular melanoma. And the CAPS guidelines, which are these guidelines I'm going to show you in a little while, which are kind of these, a bunch of centers have agreed on when to offer pancreatic screening. They believe that if you have this mutation with a first-degree relative with pancreatic cancer, that you should be offered screening. But I know some places offer it regardless of family history. And again, that is a discussion to have with your healthcare team. And so now we're going to get to the more rare syndromes. So these are rare and severe. And the two I'm about to show you actually are associated with childhood cancers or very young cancers. And so the first one is called Pitts-Yager syndrome. This is one that is pretty rare to see in a cancer clinic. It's caused by mutations in this gene STK11. And the three main features of Pitts-Yager are having very specific polyps in the GI tract, called Pitts-Yager hamartomas, having very specific freckling of the lips, and you'll see some in a second, and then an increased cancer risk at a young age. So an example of what's called mucocutaneous pigmentation, or dark spots on the lips, inside the mouth, on the fingers. This typically, you see that right away in childhood, and then they fade over time. Not to be confused, there's another condition where you actually it gets stronger over time and you didn't have it in childhood, and that's not the same thing. So this happens in everybody who has Pitts-Yager, and so it's pretty rare to not know that someone has it because it's so distinct. Most of these syndromes, there's no signs that somebody has these high cancer risks, but this is one where there are distinct findings. And so usually we know at a young age that somebody has this, but maybe they haven't found a medical provider and haven't been diagnosed yet. This also causes these polyps I'm talking about, and they themselves don't usually become cancer, but they can actually block the GI tract and cause something called an intussusception, which is not good. It's basically like a telescope. The GI tract kind of goes in on itself and causes blockage and anemia, and it's so it's more of a mechanical thing than a cancer concern. But the cancers with Pitts-Yager are these here, and they're pretty high, and the pancreatic cancer risk can be up to 36%, which is very high. That's the highest of any of these syndromes. And so anyone with Pitts-Yager syndrome gets offered pancreatic cancer screening, and at a young age, because the average age for these cancers is very young, and usually people with Pitts-Yager will get pancreatic cancer in the 40s or even earlier. And then sometimes there's a lot of these other cancers that occur in the 30s, and even one in childhood. So it's a very severe syndrome that needs a lot of medical attention, but very rare. So that brings me to the last syndrome I'm going to talk about, which is called the gene is called TP53. So the TP53 gene makes the P53 protein, which has been known as the guardian of the genome. And that's because P53 is essential for regulating DNA repair and cell division. So let's jump back for a second, and I'm going to ask you guys a question. So this is an elephant, obviously, right? And I don't know if you know this, but elephants are far less prone to get cancer than humans, which is weird because they are much bigger and they live much longer lives. So why is this the case? And this is a question that scientists were trying to figure out. And what they found was that an elephant has 20 copies of the TP53 gene. So this is the guardian of the genome. So they have all these backup copies. Now, how many do humans have? We have 2 copies. So that's probably one of the reasons that elephants seldom get cancer. And it is an evolutionary advantage that they have evolved. And so this kind of helps scientists realize the importance of TP53. Now, if you've had a tumor test on your pancreatic cancer or on another cancer, it's really common that we see TP53 mutations because a lot of mutations have to accumulate in cells before these tumors kind of progress. And so it's often that TP53 gets knocked out in that progression. And so that doesn't mean you have Lefromini syndrome, which is what we're about to talk about, but it can sometimes be a therapeutic target, or it can give your oncologist more information. But sometimes, and this is a lot more rare, we do see these mutations that are running in a family because they're germline. But more often than not, if it's found in a tumor test, it's less likely to be germline just because it is often found in tumor tests. So what is Lefromini syndrome? It's caused by germline mutations in TP53. And it is very much associated with childhood onset cancer. So the rate of a child with Lefromini that gets cancer is 4% in infancy, 22% by age 5, and 41% by age 18. So it's really high. It's also been found to play a big role in childhood solid tumors. So many times when a child has a solid tumor, so not a leukemia lymphoma, but other types of tumors, those are very often caused by having Lefromini syndrome or one of these other hereditary cancer syndromes. So it's pretty severe. For adults, the risk is up to 60% of breast cancer. And then there's these other more rare tumors, including pancreatic cancer. And then there are a number of other cancers that this is associated with an increased risk for. Again, this is one that's more rare, but really important that you see a genetic counselor or genetics professional for routine care if you have this. Okay, that wasn't the last syndrome. I have a few more. But this one, FAP, Familial Adenominus Polyposis syndrome, isn't as often thought of as one that we think of for pancreatic cancer, but we do know that there's some increased risk. But typically we know people have this. Why? Because it causes usually something called classic familial adenomatous polyposis, or attenuated. But there's also this allele that I'm going to just touch on really quick because I bet many of you have been found to have this allele. So what is FAP? So FAP is where we find many, many polyps in the colon. If somebody has classic FAP, that could be hundreds to thousands of polyps. So typically in someone's lifetime, maybe they'll have 2 or 3 polyps. These people have hundreds to thousands by their teenage years. And the attenuated form, which is a little less severe, they may have, less than 100 a little later in life. So it's a little harder to catch, but the lifetime risk of cancer for someone with classic FAP is 100%, whereas in attenuated, it's a little lower, and the average age is lower too. So what do we do for them? Typically, it's if we can screen their polyps and kind of treat them each individually, that's what we'll do. But if their colon is truly covered in polyps, then that part of the colon or the whole colon needs to be removed. And the actual severity of the polyposis and of the other cancers depends on the area on this APC gene that is affected. So when it's closer to the ends, it's usually less severe. Closer to the middle is more severe. And then there's this I1307K, which I'm going to talk about in a second. So what are the non-colon tumors in FAP? There's a number of them, but the risk is probably not as high for pancreas cancers, although it is on this differential. There's also these other tumors. So when you see desmoid tumors or bone growths or cysts or dental anomalies, those can be associated. And then there's this thing called chirpy, which is basically freckles or bear tracks on an ophthalmological exam. And I've actually had patients refer just for the bear tracks. And then we find out that they actually have this condition and we're unaware of it. So it's really a helpful thing for eye doctors to see and refer. And so most people, because this is such a severe syndrome with so much penetrance, meaning it shows up so much, the symptoms show up at an early age, most people will know they have it because there's a family history of it. But with APC, we know that 1 in every 3 cases is a de novo mutation, meaning that it is newly occurring in the child or in the patient, and it didn't come from mom or dad. And that can sometimes happen. It's more common with certain conditions. And so this isn't a reason why it's important to check, because if you do have this and you have these polyps in the colon, they do need to be controlled. And they can still pass down to children. Now, this APC I1307K variant does not cause FAP or any sort of polyposis. It is a really common variant found in the APC gene in the Jewish population. Some studies show up to 11% of random Ashkenazi Jews, meaning Eastern European Jews, carry this. And so it may be associated with increased risk for cancer, for colon cancer specifically, but it is not going to be associated with pancreatic or these others. At least there's no data to show that right now. It's very common. And so if you've had a genetic panel and you are Ashkenazi Jewish and you've had this picked up, it's more likely that it was picked up because you're Jewish and it's common in the Jewish population, not because it has anything to do with cancer risk. It does include doing colonoscopies, or it's recommended if you have this to do colonoscopy every 5 years instead of every 10 years, but you can talk to your doctor about that. So we've talked about the pancreatic cancer syndromes for the exocrine type. What about inherited pancreatic diseases? So there's this condition called pancreatitis. And what that is it's a chronic inflammation, or it's any sort of inflammation of the pancreas. And that can cause damage. And anytime you have chronic inflammation, it can increase the risk for cancer. And so the syndromes we've talked about, those genes are part of the pathway that kind of regulates cell growth, which is why they increase the risk for cancer to occur. But then we have these genes that are associated with protecting our body from this inflammation or from regulating the way that the digestive system works. And so it can cause pancreatitis when you have a mutation in one of these genes. Now, most people who have pancreatitis will not have a hereditary form, but there are forms of hereditary pancreatitis. So there's acute, which is kind of this lower level of inflammation where you have elevated enzymes, you have abdominal pain, it's for shorter amounts of time, and then that can turn to chronic, which is where you're having multiple bouts of this horrible abdominal pain, and you're hospitalized. And it progressively, if it remains uncontrolled, will damage the pancreas tissue and the function. So in certain families where we see multiple family members with pancreatitis, we find in about 60% to 100, depending on what study you're looking at, mutations in this gene called PRES1 or PRSS1. We also sometimes can find multiple mutations in SPINK1, this gene called CTRC, and CFTR. CFTR is the gene responsible for cystic fibrosis when found in certain combinations or recessive forms. We know in cystic fibrosis that there is involvement of the pancreas, right? That there's that it does affect pancreatic function. And so there's some thought of, does this affect pancreatic cancer? And I think that this is something that's going to be looked at and is being studied. There's not enough evidence to show that it is, and it's really common to carry a CFTR mutation. So probably unlikely, but that's something that we're still studying. So science. So for PRSS1, this is the reason it's so important to test is because there are families where they carry a PRES1 mutation, and some people in the family will have pancreatic cancer and some will just have pancreatitis. And so if we don't see the people that have pancreatitis and we're only seeing pancreatic cancer, we may miss it if we didn't test someone with the cancer for PRES1. So this, I would say, is really important to be on most pancreatic cancer panels. Okay, and then there's other genes as well. So that was an overview of these syndromes. And I hope I didn't bore you too much because I know there's a lot of detail. If you are found to be positive for any of these syndromes, it is so important to see a person or a specialist who has expertise in that syndrome, because you can be part of research. There's prevention and treatment changes. But I want to go over what the different types of results are. So now we're going to jump over to genetic testing. So let's say you do one of these genetic testing panels. What might you get? So a positive, there's three types of results. Positive, meaning that a pathogenic variant or mutation was found, which means that the laboratory found a version of the gene of, they may test a bunch of genes and they found a version of one of your genes that they know doesn't function correctly and creates the incorrect protein or no protein. So that's a positive result. That means you have that syndrome or you have that increased risk. There's also a negative result, which means that of all the genes that were tested, the laboratory looked at all of them and saw you had the normal version of each of those. But then there's this third result, and that's called a variant of uncertain significance, or a VUS. And what that means is that the laboratory found a version of a gene that's less common or that hasn't been studied as much. And they're not going to say it's negative or normal variation unless there's enough evidence to show that. So when the lab finds a variant or a variation of a gene that they just aren't sure what it means, they call it this VUS. And most of the time, those are just normal variation. So we don't act on those. We watch them over time. We look to see when, as more people get tested, if there's more evidence to reclassify it as negative, but we only change medical care based on a positive result. So that means pathogenic variant, not VUS. So as I said, over time, as more people get tested, we learn that maybe that variant that was found is actually normal in maybe a certain group of people. And so at that point, when there's enough evidence, it can then be reclassified as normal variation. In rare instances, it may be classified as abnormal or pathogenic. And so that's when you would want to keep in touch with your medical provider to see what that means for you later. Just another reason to see a genetics provider, whether it's a geneticist or genetic counselor, or a doctor who has specific training in genetics, so that you can stay on top of your variants. There's also lots of websites where patients can actually follow their variant over time. So now I want to tell you guys about this research that I did when I was at UCSF and what we found. So what we did is we actually offered genetic testing to every patient who was diagnosed with pancreatic cancer at the visit where they got the diagnosis. So it was really important to us that people were given this germline test immediately, because it may inform their treatment and it may help family members. And so what did we find? Well, we found that there were these VUSs, or these variants of uncertain significance, and that's okay, because that when we test a big panel of genes and lots of genes, we're going to get those. But what we did find is that 11% of the genes of the positive results had guidelines that would change treatment. And so we say about 1 in 10 of these people that were tested and tested positive for something actually changed their medical plan. And then there were also some genes that may not have changed the medical plan, but would be really important for reproductive purposes, like CFTR or some of these other genes. And then there were genes that we didn't expect that aren't typically associated with pancreatic cancer. And that's because these genes are cancer genes, right? Like we know only so much. We know that there are certain genes associated with pancreatic cancer and certain genes associated with others. But as we research more, we may find that these genes just overlap in the cancers that they're associated with. So we did a really large panel and found some of these gene changes that may not have been expected. And so I've been talking about these panels. So what does that mean? So there's a lot of options for genetic testing. You can do a single gene test where you're just focusing on one gene. You can do a syndrome specific panel. Let's say, you're just doing BRCA1 and 2. You can do a cancer specific panel, like a pancreatic cancer panel, or you can do a multi-cancer panel, which is looking at all the cancer genes. And I personally tend to gravitate towards the larger panels because, like I said earlier, there's a lot we still have yet to learn. And there can be things that change treatment for you or your family members. And so the standard of care is at the very minimum, if you have pancreatic cancer, to be tested with a pancreatic cancer panel. We do not do single gene tests anymore. That is not, what's recommended. So like I said, very minimum pancreatic cancer panel. And then many people choose to do a multi-cancer panel just because if you're already doing the testing, it can be helpful to look at other cancer genes as well. And it's the same price and the same amount of time. So those are the different panels, and your genetic counselor or whoever's ordering the test can help you figure out what the best test would be for you. Now, there's this new type of testing I do want to mention called RNA testing. And why would we do RNA testing? So I mentioned earlier, DNA is the recipe that codes for RNA, which then codes for the protein. So in the DNA, when we do this testing, we're looking at the regions of the DNA that are what we call coding or are important. So if you imagine like a magazine, there's articles and there's ads. And we know that most of the content will be in the articles, not in the ads. So you usually skip over the ads when you're reading a magazine. It's kind of like that with our DNA. We're looking at the areas that we know have substantial meaning. And the thing is, though, that there may be some changes, and it's rare, but there can be changes in the areas that aren't as important or aren't coding regions, and we call those introns. So in the areas between the important regions, there may be important genetic changes that could explain something. And so by doing RNA, we can actually look to see if the end product is more likely to be affected with a genetic change that may not be findable with just DNA testing alone. And so many of the labs are now offering DNA testing plus RNA testing just to make sure that that one, you're getting a little more coverage. And also with these variants of uncertain significance, sometimes RNA can tell us what they really mean. So it can clarify if they're truly benign or pathogenic. So with RNA testing, it can easily be done at the same time as the DNA test, but it requires a blood sample. So instead of using saliva, this would require blood. And it can clarify VUS results in a family where it's uncertain if that means anything, and can sometimes find deep hidden variants. So if you are somebody who has had a genetic test and maybe you have a lot of pancreatic cancer or cancers in your family and it hasn't been explained, and you haven't had RNA testing, in some cases that could be helpful. So we're kind of shifting towards doing RNA testing in every cancer test now. And I think the new standard of care will probably be that in a few years, if not sooner. So that's RNA testing. So now that I've gone through all of this, I just want to kind of reiterate, why have germline genetic testing? Well, for prevention and treatment. So let's go through what that means. First of all, how do you ask for this testing? Hopefully I've convinced you that, that this is worth it, but maybe you don't really know how to ask for it. So I made a little video to try and help you out.
My father was just diagnosed with pancreatic cancer, and we'd like him to get tested for all the genes associated with it. With everything your father's dealing with, it's not really top priority. I understand, but these results could inform his treatment. I'm not sure how it would change his care. Well, depending on his results, he may qualify for a more personalized treatment plan, like PARP inhibitors, immunotherapies, or certain clinical trials. Oh, well, that's new. And since he's the relative affected with pancreatic cancer, he's the best person in our family to be tested to see if there is a detectable gene change, but these syndromes are pretty rare. Actually, multiple studies have found that at least 1 in 10 cases of pancreatic cancer are associated with a hereditary gene change. Just so you know, genetic testing is pretty expensive. Well, the National Comprehensive Cancer Network recommends that all individuals with exocrine pancreatic cancer and their first-degree relatives be offered genetic testing with a multi-gene panel, so it will likely be covered. But even if it's not, the cash pay rate is $250, and that is well worth it. Wow. Things have changed quickly. Yeah, we would love a referral to a cancer genetic counselor to discuss testing and results. Okay, sure. How did you learn all this? I follow DenaDNA.
So that is my, I have a series of videos that help people ask for genetic testing for different types of cancers, and that's the pancreatic cancer one. Hopefully you understood many of the things I was referring to in that, but we're gonna go over them again anyway. So when we talk about prevention, why this is helpful, it's helpful for the patient and his or her relatives, because it could help us figure out if someone needs earlier or more frequent screening, like some of the things that I talked about with some of those syndromes earlier. And typically for pancreatic cancer, that would include endoscopic ultrasounds and MRIs. And then there's also medications for prevention, like I mentioned with Lynch syndrome and with BRCA, there are certain medications to lower certain cancer risk. There are lifestyle changes that can occur, like quitting smoking or getting in a more healthy exercise routine. There are certain things we know that can decrease the risk for cancer. And then surgical intervention as well. So these are all ways to lower the risk and to try and get ahead of it before it occurs. And again, this is helpful for the patient and his or her relatives. And so when we talk about specifically pancreatic cancer screening, this is just an example of the CAPS guidelines, which is this multinational kind of group where they these like agreed upon guidelines of who to offer screening to. But like I said earlier, it really does differ based on the medical center. But as you can see here, so having 2 first-degree relatives, that's the familial pancreatic cancer we talked about, having 2 blood relatives and 1 first-degree relative, so 3 relatives total, or just having Pete's syndrome, because that is a much higher risk. And then there's the BRCA2 that's mentioned, PALB2, CDKN2A, P16, and Lynch syndrome. And those are usually when there is a relative or family history, although that might change. So we talked about all these earlier, and no consensus was reached to when to start, but again, it just depends on the center. If you're doing pancreatic cancer screening, I recommend going to a place that has a specialist for high-risk individuals, because that's going to be kind of the best workflow. Okay, so when we talk about targeted therapy, so treatment, there's this thing called HRD, and I'm going to try really hard to make this easy because it's very complex. But there's this thing called homologous recombination repair, or HRR, which is basically our body's ability to repair double-stranded breaks in DNA. So think of it as like a repair team or a repair crew. And when a cell is HRR deficient, meaning that it is not able to repair double breaks in the DNA, then it is called HRD, or the homologous recombination deficiency. Now we also have something called PARP, which is an enzyme that's also involved in repair of DNA damage. And in healthy cells, when a DNA is broken, the PARPs may act as a repair crew to keep the cell surviving. And then there's PARP inhibitors, which inhibit the enzyme and the ability to repair. And it's a type of targeted therapy. And so when you combine HRD positive tumors, meaning tumors that cannot go through this repair mechanism, and the PARP inhibitors together, it gives really great results in being able to kill cancer cells. So the idea is to find if a tumor is HRD, if it's homologous recombination deficient. And so this is a type of targeted treatment. And this shows you here a normal cell, when given this, is going to be fine because it has these activated genes, but an abnormal tumor cell, when it's given PARP inhibitors, can actually will prevent it from repairing and lead to cell death. So until recently, it was thought that PARP inhibitors were only good for tumors that had BRCA1 or 2 mutations, but we now know that there are a handful that can be involved in this mechanism, and that these handful of genes are associated with homologous recombination repair. So when there is a mutation in one of these genes, using PARP inhibitors can be a really good treatment. So sometimes this is another reason to have a larger panel, because even though not all these genes are associated with pancreatic cancer, it could help your oncologist figure out if there's a better way to target the cancer cells. So that's just an explanation of the PARP inhibitors, which preferentially kill HRR mutation or cells with these mutations over normal cells. And then there's immunotherapy. And this actually primes our immune system to recognize, target, and destroy cancer cells that are MMR deficient. So cells that have Lynch syndrome mutations, like I said before, those are the mismatch repair genes. And so that can be another very personalized treatment that works really well if somebody has Lynch syndrome or their tumor has an MMR mutation. So those are two, the PARP inhibitors and immunotherapy are just 2 examples of how we can target treatment for someone based on their genetics. And so just to go over real quick, insurance and coverage, biggest thing I just want to get out there is that this test should never be thousands of dollars. So germline testing for these cancer panels, the patient pay rate is $250. Most people, especially if you have pancreatic cancer or a first degree relative with it, you'll most likely get it covered by insurance, but the laboratories will actually check to see how much it will be. And usually if it's more than $100, they'll call you. So it'll either be covered by insurance, or if it's not, and they're trying to charge you all this money, you can ask for the patient pay rate, which in most major laboratories is $250. So I don't want any of you spending more than that on a germline genetic test. So if you remember anything, just remember that cost should not be a barrier for this testing. Okay, so there's a few different policies to know. The Affordable Care Act prohibits insurance companies from using pre-existing conditions to affect health insurance. GINA, which is the Genetic Information Non-Discrimination Act, prohibits health insurance and employers from discriminating on someone based on their genetic test results if they're asymptomatic. So in other words, if you have one of these gene changes and you haven't had cancer, then you're covered by GINA. It doesn't affect life insurance. I mean, it doesn't cover life insurance. So that's something I tell everybody. If you have not taken a life insurance plan out and you plan on having genetic testing, I recommend looking into getting a life insurance plan locked in before you get your genetic test results. And that's just because they are legally allowed to deny coverage or raise rates based on just a genetic test. And then testing coverage, it's usually covered by commercial insurance, Medicare, Medicaid, which will cover genetic testing for most high-risk families. And then the screening involved, so if you are positive and you need to have screening, that is also typically covered by insurance. So again, cost should never be a barrier to getting good medical care. And if it seems to be, then it can be helpful to work with somebody like a genetic counselor or another type of healthcare provider that can help you advocate to get this covered. And so just want to remind you that if you do end up having a mutation in one of the genes we talked about, it does not mean that you have cancer. It just means you have a higher chance of developing it, and this knowledge will help you get ahead of it. And most people who do this test actually don't have a mutation. So if you remember earlier, I said only 10 to 15% of cancers are hereditary. And so that means that there are going to be 85 to 90% of people that are going to be negative that don't have a hereditary cancer. But if you do have one, it's really important to know that you have it. Genetic counselors are there for you and can help you guide you if you have a mutation. And so just reiterating again, I know if you like what you learned today, or you are interested in having this testing and you can't find a genetic counselor, I am seeing patients in multiple states via telemedicine. You can email me here. And then you can also go to findageneticcounselor.com, which is a really great resource. You click on either in person or telehealth and click on cancer and then put in your zip code. You could find somebody local. And then I also created this worksheet with Rolf a few years ago, and it still holds true today. And it's a great thing to fill out and bring in before you have your genetic counseling or even a doctor's appointment. Maybe you can bring it in with the script that I showed you in that other video and ask for genetic testing. But this is available on the Rolf website. And now I think, wow, 59:30. I think I hit it right on the hour mark.
You certainly did. So take a breath now, because that was a lot to get through.
Yes.
First of all, thank you for sharing so much details. We've had a lot of questions come in during our talk. And again, if you have additional questions, please continue sending them in. We'll get to as many as we can now. And if we can't get to it, then we could always ask Dena and respond back to you. I wanted to reiterate that this session is being recorded. So if you do need to pop out, it will be recorded and remain on our website as well as our YouTube channel and where you find podcasts everywhere. So let's dig into it. First of all, I want to thank you for sharing the worksheet that Ralph created with you, and wanted to share that people watching now, you can go to knowyourrisk.org to fill it out and take it in with you as Dena had recommended. So Dena, you talked a lot about the notion of passing these mutations down to your children. Can you share a little bit, if you're planning on having children, what do you do if if you have one of these syndromes and you don't want to pass it down? Is it possible to kind of halt it?
Yeah, great question. So there's a few ways to avoid passing it down. So when somebody has a single gene change that is detectable with a genetic test, then one of the things we recommend is going through in vitro fertilization and creating embryos and then testing the embryos for that genetic change using pre-implantation genetic testing for what's called monogenic diseases, so PGTM. And they can actually then only implant the embryos that do not carry that genetic change. And that it will ensure that you are not passing it down. That's one way. Now, that's expensive and it's not always guaranteed, right? So the other option, and unfortunately this now depends on what state you live in, but is testing a fetus very, very early. So you can test a fetus around like 10 to 12 weeks with a chorionic villus sampling and actually see if it has one of these conditions. And if it does, some people will choose to end that pregnancy. Now, that's not the right choice for everybody, especially if it's a gene change that maybe doesn't have as high of a cancer risk. But if it's something that has a very high cancer risk, like one of those childhood syndromes I was talking about, then it is really important. So those are two of the ways. And the other way we talk about is using an egg donor or using a sperm donor or adopting, right? Those are ways to have children, although they're not genetically yours, but that we can hope that they don't have, that same condition. So those are the ways that we recommend, avoiding passing it down.
Okay, great. So there's discoveries that are being made all the time, and hopefully, bigger and better ones as we go forward. How often should our community get tested once they realize that they need to?
Yeah, that's a really good question. So I think it depends on how big of a test you had. So the bigger the panel you have, the longer it will stay up to date. Meaning, like, if you've been tested for a lot of genes, then that will probably be up to date for a while, versus if you only were tested for a few, then you have to go back and get tested for more. So it depends on what you've been tested for, how big the panel was, when you were tested. I think it's great to check back in with your genetic counselor or whoever ordered the test every 1 to 2 years to just say, if you were negative, to just say, hey, is there anything else? Typically, if there's multiple cancers in a family and a person with cancer is tested and tests negative, then I think that's where we're kind of thinking, okay, maybe there's something that we just couldn't pick up and we want to test again. So just communicating with your provider. And the other thing too, I want to mention that I realized I forgot to put a slide in is something called DNA banking. So for people who are diagnosed with pancreatic cancer or with anything that, has a poor prognosis, it can be helpful to bank DNA. Because what that means is, let's say in 5, 10, 50 years, we know a lot more about genetics. If the person is no longer able to offer a sample, we have this banked DNA that we can then go to and test. So then it's as if it's like an insurance plan, ensuring that we have that sample to test later when our technology is better.
Wow, that's fascinating. So our next question is, what if my doctor ordered germline genetic tests and I've been told it's going to cost me, let's say $2,000 or higher, which is obviously way higher than the $250 that you mentioned.
Yes.
What's the script there? Do you have a TikTok video for
that? Well, so first of all, if a doctor's ordering that and you can just ask what company they are ordering from, and then you can call the company and just say, I don't want to pay, or you can ask them what the out-of-pocket will be, and then you can say, what's the patient pay rate? Or you can ask the doctor to do it for you. So you can switch over to just patient pay if you're worried that it is going to be thousands of dollars, because you can, when you're ordering the test as a healthcare provider, you can click on if you want to use insurance or if you want to do just straight up patient pay. I have all my patients do patient pay just because it's easier, but I also, like, many people can get their insurance to cover it. So it's usually not a problem. I would say though, talk to your doctor about it. And if for some reason the lab is still saying it's going to be thousands of dollars, ask your doctor to either order from a different lab or get a referral to a genetic counselor, because that's a big part of our job too, is making sure that your insurance covers it. And if it doesn't cover it, then we get the patient pay rate for you.
Great, thank you. So do you think, based on what we know from genetics, that the age for testing for cancer should be lowered in general? So for example, if so many people are walking around with Lynch syndrome but aren't aware, they might not be getting their colonoscopy until 35 or older. Whereas if they were able to get tested earlier, things would be found.
Absolutely. I think as the testing is cheaper and more available, and as more population genetic testing is happening, meaning that like testing everybody regardless of any history, I think that we're going to be able to find more of those people. But I know a lot of people truly believe that everybody should be tested in their 20s, because that's really when a lot of the screening starts. And in some really rare cases, it can be maybe even like late teens, but usually 20s is a good time to get tested. And so I think it will be really nice one day in the future when everyone will be offered that testing. Yeah. And we'll find a lot more.
For sure. How about, so somebody said, my doctor recently sent me a mail-in genetic test. I know we talked about that during our previous session. And they're asking, how do they know if it's a genome or a tumor test, or something totally different?
So it depends on if it's mail-in, it means that you're probably spitting or providing blood. So that's probably germline, because a tumor test would need to be done on the tumor. And my guess is you don't have like the tumor in a jar at home. So, so probably that is a germline test. It also depends on the company. Like some of the companies I named earlier, like Invitae, Ambry, Color, Myriad, Natera, some of those, they offer these at-home tests. But yeah, I mean, you want to make sure that the panel that was ordered is a large enough panel. And if you have questions, then it could be helpful to see a genetic counselor who can just make sure that you're getting the right panel.
Okay, great. So we talked a lot about the increased risk for Ashkenazi Jews. We also know that there is increased risk among Black Americans as well. So are the signs different for Pitts-Jaeger syndrome? Are they the same for people of color? Do the easy to spot dark spots show up on darker skin, or is there any other details that you can provide?
Oh, that is such a good question. That's such a good question. Yeah, I'm trying to think if I've ever actually seen a patient with darker skin on that. I do believe that it's pretty, because it shows up on areas that aren't as pigmented. So you can usually notice the pattern. But yeah, it's a really good question. I think okay, so I'm going to address the first thing you said, which is that it's also really, there's an increased risk. So for BRCA, for example, we know 1 in 40 Ashkenazi Jews carries a mutation. We know that between that and the normal population, when I say normal, I mean general population, we have the incidence in the Black community. So one of the projects I'm working on with a Previver is called Black Cancer Genes, and we're educating people about it because there is a higher rate of these hereditary mutations found in the Black community, but they're 16 times less likely to be referred to genetics. So it's really important that doctors don't just assume, okay, it's just Jews that have BRCA, or okay, well, you're not white, so you can't have that, because that's not the case at all. In fact, they're more likely than a typical, European person to have it. So yes, so we do know that there are, and we're learning more as we learn more, as more people in different ancestry groups get tested, we're learning more about the frequencies in different groups. One of the reasons we know so much about Ashkenazi Jews is because it's a very well-studied population, but I do think that there are these mutations in other populations that just aren't as well studied, but we're working on catching up in the whole field of genomic medicine. So I think we'll know more, in the future, and as we do more population genetic testing. But yeah, when you're talking about the pigmentary changes, that's a really good question. I don't know the answer to, so I'm gonna have to look that up.
Okay, well, I appreciate your candor on that, and appreciate what you're working on to bring the equity up to speed. So during the talk, you talked about a lot about childhood cancers. So is there an age that you suggest for kids for genetic paneling? Is there something that's too young, too old? Is there a sweet spot?
Yeah, so usually with most of those childhood cancer syndromes, there is a family history of it. So like if there is a relative that had a really young cancer, then hopefully they were tested. If they were not, then yeah, like other relatives should be tested. So for instance, with Lefromini, that's the one that has a lot of the childhood cancer, we do often see family history. But that being said, it really is a spectrum. And I've seen cases where it's very questionable because they have a TP53 germline mutation and they don't have childhood cancer. And it's very confusing because we really don't understand the full spectrum of Lefromini, because most of the people we were studying were those that had really severe early cancers. And we weren't studying those people that went under the radar because we didn't know they had those mutations. So I think there's no like recommendation for children to have this genetic testing at this point in time. And it is very rare. So it's pretty unlikely to happen, in the normal population. But if there is a child in a family that has cancer, it is really important, especially if it's a solid tumor in childhood, that person gets testing. And then hopefully it will inform the rest of the family on their risk.
Okay. So you talked about TP53 as the guardians. Is there anything that we can do to further protect or empower our TP53?
That's really funny. Well, we know that smoking is a risk factor for some of these random mutations. And like there's different life, the things that you're told not to do because it can cause cancer, often those are types of things that can interfere with those genetic pathways and cause those random changes. So, eating whole foods, exercising, not smoking, those are just some examples of how we can keep those random changes from happening.
Okay. So it seems like, for lack of better phrasing, that guidelines for pancreatic cancer and genetic testing are a little wishy-washy, to be technical. Do you think that more stringent guidelines and more consistency within it would lead to better results or better result on early detection? Or does one not play into the other?
Yeah. Okay. So here's how I think about it. So we all kind of know, like, for instance, colonoscopy, it's been proven, there's lots of evidence to show that it really does decrease risk for colon cancer. But for a long time, we didn't know that until we did it on enough people that there was enough evidence to show that this is a really good intervention and can lower risk for cancer. We are in those early stages of pancreatic cancer screening where we don't really know if there is going to be evidence to show that this really significantly decreases the risk or increases the chance of finding it really early, until we've done it on enough people. So I think of this as more like we're in the research phase, which is why there's no standard, right? Because there's not enough evidence to show that what the standard should be. So I think if you are one of these high risk, or an individual from a high risk family, or you're considered high risk for pancreatic cancer, making sure you find a local high risk screening clinic. So I know, for example, the University of Chicago in Illinois has, I believe they have a high risk pancreatic screening program, and they are a group of specialists who are going to be up to date with the most recent recommendations. They may even participate in research. And so that would be the best thing to do, is to find a center that's very specialized in high-risk pancreatic screening. And I think like in the future, it will get better, but there's a lot to learn about if it's truly helpful or not.
Sure. So Dena, all of this is, when you look at it as a whole, it's very heavy. Mm-hmm. So what advice do you have for somebody looking at this in our community, of looking at this and saying, my gosh, I don't even want to know. I'm too scared to go, or, what advice do you have for them to kind of ease them into it?
Yeah. Okay. So I should have said this at the beginning, that the really scary syndromes are very rare, and most of the time there's signs that they're there, like the childhood cancer or the freckling and Petechiager. So most likely you're not going to have one of those. If anything, you'll have one of these like more moderate types of syndromes and risks. And so the main thing is that knowledge is power. So knowing this information can help give you control. And a lot of times when you're scared and you don't want to know, it's because there's going to be this uncertainty of what to do and what your risk is. And the risk is there whether you do a test or not, right? Like you're going to have the mutation whether you do the test or not. So, you're going to be, oftentimes I find the anxiety that that's associated with just not wanting to know is way worse than actually doing it. Because first of all, most people are negative, and that will just take so much weight off your shoulders. But if you are positive, and I've had many patients who are happy to be positive because it gives them a plan. They have a plan going forward, and they have the knowledge and they understand what their actions are going to be. And so they can take control of their risk by using that information, going forward. So it's just, you have to remember that the risk is there whether or not you choose to know. And oftentimes you're going to be happy to know rather than like be in the dark, right?
For sure. And I think, having genetics counselors like you and others, and then having the Rolf team who is connected to so many, that you have what you need to do, and then figure out the people who can get you there. So that makes a lot of sense. So we always wrap up our sessions with what are the top 3 takeaways you want our community to walk away with tonight?
Okay, well, I hope that wasn't too heavy, that I scared someone from testing, but I think a lot of people will ask, what are these genes that are being tested? And so this is kind of a little deeper dive into that. I think my main take home points are, 1, knowledge is power. Knowing this information most of the time ends up lowering anxiety rather than raising it, because you have the more control, or you find out you're negative, right? 2, if you are somebody who has pancreatic cancer, or if the person in your family who has the cancer is still living, it's really important to get them tested or bank their DNA so that you can test the person who's affected, just because that will be much more informative than testing somebody who's not affected, because they may not have inherited whatever is in the family. So, testing the person who's affected. If you are watching and you're affected, making sure that you have the germline test as well as the tumor test. And then the third take home point is that price should never be a barrier. So if you're being told it's thousands of dollars, scratch that, cancel it, see somebody who can order it and get you that patient pay rate, or ask your doctor or the person ordering for the patient pay rate.
Well, thank you. This is all such helpful information, such important information. And the best part is that you break it down so that it is understandable. You're taking these huge concepts and sharing it with us in a way that, is easy to understand, even though it's, there's a lot there. So I really appreciate everything that you're doing. And I love that we get to partner together on this.
Yes, thank you. Thank you so much. This was great. I hope, again, I hope it wasn't too heavy, but I hope people learned something and found it interesting. And if anything, you can leave knowing that elephants don't get cancer.
That's true. So Dena, we'll make sure that we have your contact information in the chat, and then any other questions that come in, we'll be sure to get your way. But thanks again for joining us tonight.
Awesome.
All right. Well, thank you everybody else for joining us as well and sharing your questions. If you're catching this on the replay, be sure to write replay in the comments and ask your questions so that we could get to Dena and get back to you on that. You could stay tuned to Rolf's social channels to find out details on next month's Wellness Wednesday. And as always, if you have ideas for topics, speakers for future Wellness Wednesdays, please email us at info@rolffoundation.org. Don't forget to register for Brushes with Cancer on September 15th and Friday night Lights of Hope on November 11th. On behalf of everyone at Rolf Pancreatic Cancer Foundation, thank you for joining us today. And until next time, we hope you stay healthy and take good care. Good night.